Definition: vesicoureteral reflux is the retrograde passage of urine from bladder into the upper urinary tract. The video.
I understand our daughter Elizabeth had a urinary tract infection, and our doctor had treated her with antibiotics. Would you be able to give us information about the reflux that was found on the VCUG?
So normally urine flows from the kidneys down the ureters into the bladder. Vesicoureteral reflux occurs when urine from the bladder flows back into the ureters all the way up into the kidneys. This occurs if the valves at the bladder do not work properly, and about 1/3 of children with urinary tract infections have vesicoureteral reflux, which is graded on a scale from 1 to 5. Urine can back up only a short distance, and that would be a grade 1, or all the way up and dilate the ureters into the kidney, and that would be a grade 5. This allows bacteria from the bladder to get to the kidneys, causing kidney infections with back pain, fever, or chill. Repeated or severe kidney infections may cause scarring and rarely lead to high blood pressure or later in life complications during pregnancy or kidney failure.
Allows bacteria to get causing infections with back pain, fever, severe kidney may cause rarely lead to high blood or later in life complications during pregnancy.
Vesicoureteral reflux. This disease is the most common urologic diagnosis in children, occurring in approximately 1% of newborns and in as many 30 and 45% of children with urinary tract infection. Vesicoureteral reflux current management is based upon the long-held belief that this pathology acts as a risk for renal scarring.
Hello, I'm Peter Feniak. The doctor has told you that your child has been diagnosed with vesicoureteral reflux. As a parent myself, I know you'll have questions, so during this video, I'll explain what vesicoureteral reflux is, why reflux is a problem, and how reflux can be managed. Later on, we'll ask you to fill out a confidential survey indicating which treatment you prefer.
Hello, I'm Peter Feniak.
The urinary tract is made up of 2 kidneys, 2 ureters, the bladder, and the urine, and those with mild reflux have the best chance of outgrowing it. Children under the age of 1 may outgrow it in just a few years. For others, it may take longer for the reflux to go away completely. Reflux is usually a congenital, inherited trait. That means people are born with the problem and it tends to run in families. If a child has reflux, the chances of any of his to prevent urinary infections. Another choice is open surgery to correct the reflux. And the third option, about 2 out of 10 of them will outgrow their reflux each year. This means that some children
is usually a congenital, inherited trait. That means people are born to run. If a child has the chance of any of his to prevent urinary infections. Another choice is open surgery to correct the reflux. And about 2 out of 10 outgrow the reflux each year.
Vesicoureteral reflux. Vesicoureteral reflux is a condition where urine flows backwards from the bladder to the kidneys through one or both ureters. Grade 1, urine flows back into the ureter only. Grade 2, urine flows back into the ureter and renal pelvis. Grade 3, the ureter and pelvis appear mildly dilated. Grade 4, the ureter and pelvis appear moderately dilated. Grade 5, the pelvis is severely dilated and the
Kidneys through ureters. Grade 1, urine flows back into the ureter only. Grade 2, it flows back into the ureter and renal pelvis. Grade 3, the ureter and pelvis appear mildly dilated.
Antibiotic prophylaxis. Medical treatment with prophylactic antibiotics remains the mainstay of initial management of vesicoureteral reflux because vesicoureteral reflux is spontaneous resolve in most of children. Medical management allows this natural history to take its course while providing some measure of protection against recurrent UII and renal injury. This is like animation. Antibiotic prophylaxis. Prophylaxis should be started once as a child has complete treatment of initial UII and continues at least until managing reverse vesicoureteral reflux. If no vesicoureteral reflux is seen, prophylaxis is discontinued. If vesicoureteral reflux is present, prophylactic antibiotics are continued until vesicoureteral reflux resolves or vesicoureteral reflux is surgical correct or the child grows old enough that prophylaxis is deemed no longer necessary. Virtually all children with a new diagnosis of grade 1 for reflux and some with grade 5 are given a trial of medical treatment. This consists of